Good morning, everyone. In recent years, approximately 20,000 Iowans have been diagnosed with cancer annually, and the stated rate of cancer incidence ranks second highest in the United States. And that's why last year I announced a $1 billion state investment to research what's driving Iowa's high and rising cancer rates so that we can start to reverse this trend. Today I'm pleased to be at the Department of Health and Human Services with Director Johnson, State Medical Director Dr. Cruz, and the HHS team. And we are extremely grateful to be joined by leaders and faculty from the University of Iowa's College of Public Health, including its Dean, Dr. Edith Parker, along with Mary Charlton and Dr. Jake Olison. Together, this team, including physicians, epidemiologists, biostatisticians, behavioral health scientists, and other experts, are researching the key drivers of cancer in Iowa. The first phase has been focused on behavioral and demographic risk factors, and once complete, will expand to genetic and environmental risk factors this summer with the goal of better understanding the problem so that we can more effectively solve it. I had the opportunity to meet with the research team last month so that they could brief me on the initial findings. Their work is impressive. It's the most comprehensive study of cancer ever undertaken in our state, and as far as we can tell, the only study of its kind in the country currently. Today, the research team is here to provide Iowans an overview of their initial report, which will be published online today. So I want to be clear before we go any further that the research is far from complete. There are no easy answers to our questions today, but as you'll see, there's compelling evidence that will continue to inform the research as it moves forward. And as each phase of research concludes, I'm committed to sharing those results in a timely and transparent manner. Because I know how much this information matters to every single Iowan that has been impacted by cancer, including my own. Before I turn the podium over to Dr. Parker, I want to say how grateful I am to her and her team. The professionalism and passion that they've brought to this work is only matched by the genuine care that underlines it. When we met recently, they opened their presentation by saying, while this report includes a lot of numbers and stats, we should never forget that each one is a person whose life has been changed by cancer. And that certainly rings true for me, and I deeply appreciate the work that this team takes, it to heart every day in their work. And now I want to invite Dr. Parker to say a few words. Dr. Parker?
Thank you so much, Governor. And I really want to begin by thanking Governor Reynolds and the Iowa Legislature for the support in making this project happen. I also want to thank Director Johnson, Dr. Cruz, and his team at Iowa Health and Human Services for their collaboration and support in this partnership. We want to start by, as Governor Reynolds said, by acknowledging that cancer is a devastating diagnosis that is life-changing, and this is what is driving our work to better understand Iowa's cancer rates. Fully answering the question of why Iowa has a higher rate of new cancers when compared to the national average would require data from 20 to 30 years ago. And we would need data on each individual in the state, including what they ate and drank, where they lived, exposures to pesticides, chemicals, household products, radon, nitrates, coupled with their genetic profile. This kind of individualized information is not collected nationally or in Iowa, so we must rely on the data we do have, and we do have data available. We are using existing data to answer the question, why does Iowa have a higher rate of new cancers than the national average? We're starting this complex project by first looking at the relationships between cancer and the demographic and behavioral risk factors for which we have existing data. Once we've established the relationship between these factors in Iowa's cancer rates, and we build a base model on which we can layer additional data, then we will move on to examine the contributions of genetics and environmental exposures using the best available data. I do want to note that we're currently, in this year, identifying sources of those data that will be used in Phase 2 next year of our analysis. I want to emphasize that this analysis is looking at statewide and county level data and not individual level data. I want to also emphasize how complex cancer is. and that there are many people who experience cancer without experiencing the risk factors that we will share today. For example, I think we all know people who got cancer and have no known risk factors for that cancer they got. We began our work in July 2025 after receiving funding from the Legislative Assembly, and with that funding, as Governor Reynolds noted, we compiled a team of epidemiologists, cancer experts, biostatisticians, and cancer prevention experts. This is a 2-year project, so we're about 1/4 of the way to completion. We were asked to examine breast, prostate, melanoma, lung, colorectal, and HPV-related cancers. Today we'll be talking about our interim findings report, and we will focus on the statistical analysis part of the project. Our presentation today will first focus on the 5 most common cancers, showing them in relationship to national trends in neighboring states. We will also present comprehensive modeling and mapping efforts for prostate and breast cancers today. Lung, melanoma, colorectal, and HPV-associated cancers will be analyzed next using the same modeling and mapping methods. This will be done by July 1st, 2026. In year 2 of the project, we will do the analysis of the environmental and genetic data, as well as develop recommendations for evidence-based cancer prevention programs. Before I turn this over to my colleagues, I just wanted to highlight some of the key points from our analysis today. First, an estimated 2,582 more Iowans aged 20 or older were diagnosed with cancer in 2022 compared to the number of cases that would have been expected if Iowa experienced the same sex, age-specific rate of cancer as the U.S. as a whole. Among the 5 most common cancers, prostate, breast, melanoma, lung, and colorectal, Iowa's incident rates are largely driven by early-stage cancers, except for lung cancer, for which we have higher rates of late-stage cancers. Iowa's mortality rates are similar to the U.S. for the 5 most common cancers, except for lung cancer, which has a higher mortality rate in Iowa. The cluster of states that are similar to Iowa in terms of demographic and behavioral risk factors had the highest or among the highest rates of all cancers combined, as well as each of the 5 most common cancers. Based on the risk factors assessed at the state level, our models predict Iowa to have higher cancer rates than the national average. Iowa's rates are still higher than predicted, but the amount varies by cancer type. Based on the risk factors assessed at the county level, our models predict that some counties had a significant higher than expected rate of cancer, which differs by type of cancer. Counties that were identified as having higher than predicted cancer rates after accounting for the effect of behavioral risk factors and demographics are places where it would make sense to look at other risk factors, such as genetic or environmental factors. But I want to be clear, this is not to discount the high rates in other counties that deserve attention in reducing their burden of cancer. Now I'd like to turn it over to Professor Jake Olson of the Department of Biostatistics and Professor Mary Charlton of the Epidemiology Department, who will walk you through more detail of the findings.
As Dr. Parker mentioned, a really frustrating thing about cancer is how complex it is. It is caused by a different combination of genetic, lifestyle, and environmental risk factors. And these factors can cause cancer to develop over many years, sometimes decades. It is also important to remember that 2 things have to happen for people to be included in these cancer rates. First, they have to develop cancer. And second, someone has to find the cancer and diagnose the cancer. Some people have cancer and never know it. They may die of something else before they experience any symptoms, or their cancer never grows into something that causes any symptoms. That is where the right side of this picture comes in. Demographic characteristics can be strongly associated with access to and use of healthcare services, as in the kinds of services that can detect cancer. In this interim progress report, we will be thus focused on the factors that are shaded in green. We will use them to construct our base models on which to layer additional information and data, and we will be examining the factors in gray in the next phase of this project. So, as a background, how do cancer rates in Iowa compare to the US? And then Dr. Olson will go on to say, how do the rates translate into the actual numbers of excess cases in Iowa? This graph is just to show, kind of in one scale, the degree to which each type of cancer pulls Iowa away from the US trends or pulls it closer together with the US trends. You can see on the far right, in the green, is prostate cancer. That is the cancer that's pulling our trend furthest away from the US. It's a very common type of cancer, followed by breast cancer, followed by melanoma, and lung cancer. Colorectal, while one of our most common types of cancer and a cancer for which we have high rates, our trends are actually close to the rest of the US and are getting closer, which is why they're on the bottom in the green. And then you can see there's lots of cancers in between that we're not going to talk about today that may be slightly pulling our rates away to a lesser degree. But this shows why we're going to focus largely on prostate, breast, melanoma, and lung cancer. So now in terms of our trends over time, as you can see, breast cancer in the orange, prostate in the green, dark green, and melanoma in the pink have all been increasing more steeply in Iowa since around 2013, with Iowa being the solid line and the US being the dashed line. Colon cancer, as I said, is higher in Iowa compared to the US, but it has been decreasing at about the same rate as in the US. While lung cancer is decreasing in both Iowa and the US, it is decreasing at a much slower rate in Iowa, and the difference continues to widen over time. Now we're switching over to mortality, age-adjusted mortality. So you can see, fortunately, most of our cancers follow the US trends in mortality. We are not higher than those. The one exception is with lung cancer, where you can see our mortality rate is higher compared to the rest of the country, and that is because, unfortunately, that is such a deadly type of cancer. And with that, I'll turn it over to Jake to talk about how this translates into the actual excess numbers of cancer cases.
We saw that the age-adjusted rates are a nice way of making comparisons between the cancers and Iowa with other states, Iowa with national average. And we want to understand more about why those age-adjusted rates are different. We're going to break the numbers down in a slightly different way. One thing we're going to look at are age-specific rates. There might be some age groups that have higher rates than the national average. There might be other age groups that are not as high. And we're also going to look at the numbers in terms of the number of Iowans. We see that the age-adjusted rates are different. How many Iowans does that actually correspond to? That's shown in this figure here. I'm going to focus mostly on the far right-hand slide, which is 2022. The top of the purple is the observed number, the 20,615 cases of cancer in Iowa in 2022. The bottom of that purple, the top of the white, is what we're calling the expected or predicted term, 18,033. That's the number of cases that we would predict in Iowa if we were exactly at national trends. And the way that's calculated is by looking at age-specific and sex-specific rates. 20 to 25-year-old females, what's the national rate? And apply that to the number of 20 to 24-year-old females in Iowa. And how many cases does that correspond to? Do that for every age grouping, both male and female, add them up, and we arrive at this number to be the predicted number in Iowa if we followed exactly national trends. We saw 2,582 more cases in Iowa than we would have predicted if we followed exactly those national trends. We track that back. This slide goes back to 1999. We've always been high at that upper limit, and there's a black bar in there for a statistically significant difference. How far above the expected is the observed, and is that a significant difference? We've always been a little bit high, going back to 1999. It's colored in purple if there's a significant difference. It'd be white if it's not. That number increases around 2014 and continues to increase there. So going forward, we're going to talk more about excess cases and break down these specific numbers. We took that approach for the cancers that we've already mentioned, melanoma, lung, prostate, colorectal, and breast cancer. Of the 2,582 cases, how many of those correspond to specific cancers? If Iowa followed exactly age, sex-specific trends for melanoma, that's our largest. We had 400 more cases than we would expect if we followed national trends. That is about 15% of our overall excess cases. Lung cancer would be 376. We had 376 more cases in 2022 than we would predict based on that national trend. Melanoma and lung together make up about 30% of the total number of excess cases. Prostate cancer, still 331 excess cases. Colorectal, 189. Breast cancer, 141. In total, those 5 cancers represent 55%, a majority, over half of the excess cases relative to national trends, which means there's still 44% that's explained by all of the other cancers that Dr. Charlton had on a previous slide. Well, now that we've set the stage for each of the individual cancers we'll be examining, we want to turn to the behavioral risk factors and demographic factors and look at which states might we be different from and which states are we similar to for these demographic risk factors. So state level comparisons. Here's a map that shows in our clustering algorithm which states are the most similar on these demographic risk factors and behavioral risk factors. Things such as percent of the state that is binge drinking, percent of the state smoking would be the behavioral. The demographic, percent of the state with college education, or percent of the state with that's insured. These are the groupings, and Iowa groups together on these factors with Wisconsin, Minnesota, North Dakota, South Dakota, and Nebraska. If you want to see a little bit more of how the states group together in that way, these are some of the individual variables. There are 8 figures on here. I'm not going to go through them all. Of the eight of the variables that went into that clustering algorithm. Each of those individual dots are the 50 states, and they're colored by the same color scheme that was on the previous slide. The Iowa's group is always on the right-hand side in a light blue. Iowa itself is in a dark blue. For bachelor's degree, we see that the percent education, our grouping of states is usually in the national average, which is the black line going across the middle, with Iowa being on the lower end of this grouping of states. On the far right is the percent of 19-year-olds and older that are insured. And our grouping of states has higher insurance rates. And Iowa is among the highest of those, meaning that Iowa, we have good access to care. On the bottom, binge drinking, obesity, vegetables, not eating your vegetables is one on the far right. The binge drinking, our grouping of states is certainly larger, and Iowa is among the highest of those. So this is how the states were grouped together, only on risk factors. Now we're going to turn that and relate that to cancer rates. This figure takes those state groupings and puts them together going back to 2008. Focus on 2021 and 2022, where you can see that the Iowa cluster, the entire group of states together, has the highest cancer rate. So it's not just Iowa, it's the entire grouping of states, and which are similar based on risk factors.
So that was a really important analysis that Dr. Olson's team did, because then it allows us to say, how similar or different are we then in terms of our cancer rates from our neighboring states that have similar characteristics to Iowa? So among the similar states in Iowa's cluster, Iowa still has the highest overall rate of cancer. But you can see that the trends are somewhat similar among the states. Most of them have trends that are above the US average, which is in the black dotted line. And you can see for mortality for these states in Iowa's cluster, all are very similar to each other and similar to the US average, all fortunately declining. I did want to call out our incidence rates for lung cancer. This is one cancer for which we are not like our neighbors. We have a higher rate and have had a higher rate for the entire time period that we looked at, and the difference seems to be widening. And unfortunately, this plays out into lung cancer having a higher mortality rate in Iowa compared to our neighboring states. Although fortunately declining, as I mentioned, it's not declining as a rapid rate as it is in other states. Some good news on the left-hand side is that when we look at incidence rates by stage for states in our similar cluster, you can see that compared to our neighbors, our increase is really the biggest in localized, or those are those early stage cancers that haven't spread to any other parts of the body. Regional stage refers to those that have gotten into the lymph nodes or some nearby organs, whereas distant cancer is what you think of as metastatic cancer. They've spread to distant sites. So while it's good on the left-hand side that our increase is biggest in localized or early stage cancers, you can see unfortunately on the right-hand side that we still have a higher distant stage or stage of metastatic cancers compared to our neighbors. And lung cancer is largely responsible for that difference. You can see in our incidence rates by stage, for states in our cluster for lung cancer, all our states kind of follow similar patterns for localized and distant cancer, but Iowa's is much higher for that distant or metastatic cancer. So now you may be wondering, before Dr. Olson compared us to the US rates to calculate excess cancer trends. Now he's going to compare us to our neighbors to see how many excess cases do we have compared to other similar states in our cluster.
In order to do this comparison, on the first two columns of this are it's the same table that we had before, which is the number of excess cases relative to the national trend. Now we recalculated that and said how many excess cases would we have if our comparison group was those other 5 states, Wisconsin, Minnesota, North Dakota, South Dakota, and Nebraska. If we were exactly like those, then how many more or fewer cases might we have? Melanoma is the first one that's on the list. Relative to the national average, we have 400 more cases. Relative to this grouping of states, that is 26, which is not a statistically significant difference. We're very similar to that grouping of states in terms of melanoma. We have similar results for prostate cancer and breast cancer, where that excess cases number relative to our grouping of states is considerably smaller and not significantly different from our grouping of states. That's not true for lung cancer and colorectal. Lung cancer number, the number of cases excess is still considerably high, and colorectal even went up when compared to this other grouping of states. Go down to the total row where it was 2,582 excess cases across all cancers. That is now 1,298 relative to just our grouping of states. So that number has been cut roughly in half. So half of the excess cancers are roughly attributed to what's similar to these other states that we're similar to, leaving half that where we're different still from those other states. Now that we've done these state level comparisons, we want to dive into specific counties in Iowa. Take these same methodological approaches and calculate excess cases per county in Iowa. And if that county followed exactly national age, sex specific rates, which counties are significantly higher than that national average. And there's a lot of information on this figure. We'll put them all in here. We see all cancer sites, prostate cancer, and then for breast cancer, we split it into two parts. Premenopausal breast cancer for women ages 20 to 44, and postmenopausal breast cancer ages 55 and over. We do not have, this is an interim report, we're still diving through the numbers. We have not finished lung, colorectal, melanoma, HPV yet. Those will be coming later. These are what we have for now. So for all cancer, you can see most of the counties are listed in purple. There are high rates across the entire state. And 87 of Iowa's 99 counties are listed as significantly higher than the national trend. And this is unadjusted numbers, without adjusting for any other factors other than age and sex. And in prostate cancer, there's a grouping of counties in the west and northwest Iowa, and another grouping of counties east, northeast Iowa. Premenopausal breast cancer, there are no counties that are listed here as being significantly different from national trends. That would be, and then postmenopausal breast cancer, there are 11 counties that are listed as being significantly different from national trends. And one thing to point out from this is that the patterns for prostate cancer and breast cancer, there are different geographic patterns. The different counties are showing up for the different cancers. Now it is time to bring in the behavioral risk factors and see if that changes which state, how Iowa relates to other states and the counties, starting with the states. We went through a lengthy variable selection process to determine which variables that we want to use as predictors of these rates, and we use, in this case, the percent of the state that's obese, the percent of the state that's binge drinking, the percent of the state doing a checkup in the past year, and the percent of the state that's white, non-Hispanic. Using those variables and how all 50 states score on those variables and how all 50 states have age-adjusted rates, can we predict what Iowa's age-adjusted rate would be based on the relationships of the other states. The U.S. rate is 621.7, and Iowa's all-cancer rate is considerably higher at 691.9, but using these factors, we can predict that Iowa would have a considerably higher all-cancer age-adjusted rate at 670.7, which is about 70% of the way there. So we do predict that Iowa would have a high cancer rate. But there's still other factors that could lead into this because we don't predict it all the way. Again, we'll move through the other cancers that we've looked at so far. Next is prostate cancer. There's a larger list of variables that were included in this through our selection process. The U.S. rate is 163.2. We already saw that Iowa's rate is considerably higher at 181.6. And using these variables, we predict almost 90% of the way there. We predict that Iowa's rates would be higher at 179.5. Could you go back one slide, please? Thank you. Premenopausal breast cancer. These rates, we already saw that Iowa's rates were not too much higher. There's still 53 for the U.S. rate, 55 for the Iowa observed rate, but putting these variables in the model, we'd predict that the rates are higher than the national trend. And then the postmenopausal breast cancer, again, predicting that Iowa's rates would be higher than the national trend. And this one, the prediction is not as high, but it's still higher than the national trend, and there are other factors then that we would want to be looking at. And now, back to the counties. We want to use that same modeling that we use for the states, use the same variables that we use for the states, and predict after adjusting for those same risk factors, which counties are still significantly higher than we would expect after controlling for those risk factors. So all cancer, almost all counties were significantly high on their own, so there's cancer everywhere within Iowa. Once we control for those risk factors, there's a smaller grouping of counties that remain significantly high. And these would be counties that in the next phases might be of interest to look into some of the other factors that we want to look at. For prostate cancer, we still have a grouping of counties in the northwest Iowa, but it is much smaller after controlling for those risk factors. And in eastern Iowa, Lynn County remains high. For the first time, we see yellow counties. These are after controlling for risk factors. These counties had lower age-adjusted rates, lower number of cases than we would have predicted based off of those risk factors. Premenopausal breast cancer, 2 counties showed up high for us, significantly higher than we would predict after adjusting for these risk factors. That's Tama and Johnson County. And a number of counties are lower than we would have predicted. Then postmenopausal breast cancer, there are 3 counties, Harrison, Warren, and Washington, that were higher than we would have predicted after adjusting for these risk factors. And again, a number of counties with lower cancer rates than we would have predicted. So none of the counties that we looked at, there were 3 counties that were high with all cancer and prostate cancer. There was 1 county that was high with all cancer and premenopausal breast cancer, but no counties that were high in both, or high after adjusting for risk factors for both prostate and breast. And we're going to continue doing that comparison as we add in more cancer to our list. So a recap and what the next steps are. We've spent the first 6 months based on the risk factors assessed at the state level. Our models predict Iowa to have higher cancer rates than the national average. Based on the risk factors assessed at the county level, our models predict that some counties had a significantly higher than expected rate of cancer, which does differ by cancer. And over the next 18 months, counties that were identified as having higher than predicted cancer rates represent some of the biggest opportunities for further analyses. We're next going to analyze lung, melanoma, colorectal, and HPV-associated cancers using the same methods we just presented. And that summary should be completed by July 1st, 2026. And in year 2, we'll continue the analysis of environmental and genetic data, as well as potential evidence-based prevention programs. So to repeat the key points that Dean Parker started with, we had an estimated 2,582 more Iowans, adults, were diagnosed with cancer in 2022 compared to the number of cases that would have been expected if Iowa experienced the same age-sex specific rate of cancer as the U.S. Among the 5 most common cancers, which were breast, prostate, melanoma, lung, and colorectal, Iowa's incidence rates are largely driven by early-stage cancers, except for lung cancer, for which we have higher rates of late-stage cancer. Iowa's mortality rates are similar to the U.S. for the 5 most common cancers, except for lung cancer, which is worse in Iowa. The cluster of states that are similar to Iowa in terms of demographic and behavioral risk factors have the highest or among the highest rates of all cancers combined, as well as each of the 5 most common cancers. Based on the risk factors assessed at the state level, our models predict Iowa would have higher cancer rates than the national average. Iowa's rates are still higher than predicted, but the amount varies by cancer type. Based on the risk factors assessed at the county level, our models predict that some counties had a significantly higher than expected rate of cancer, which differs by cancer, and counties that were identified as having higher than predicted cancer rates after accounting for the effect of behavioral risk factors And demographics are places where it would make sense to look at other risk factors such as genetic and environmental.
That's okay. Well, thank you, Edith, Mary, and Jake. Not only is your work impressive, it's incredibly important in our fight against cancer in Iowa. Your research will help identify the solutions that we need to reverse the cancer trend in our state. And I also want to reiterate your comments that cancer is a complex disease and that there isn't one single cause driving Iowa's cancer rates. Today, we saw that there are several behavioral risk factors contributing to cancer in Iowa. The good news is that each of us can change our behaviors to reduce our risk. Still, I understand why so many Iowans want to find that one cause of cancer. When someone you love gets sick, it's natural to want to put all of your energy and resources into one thing that might stop it from happening again. And I wish the answer was that simple as well. But know that the research will continue to look at all of the evidence, including environmental factors, and will act accordingly based on what the research finds. That's really, truly, the entire purpose of this study. So even though the work isn't done, our mission is clear: to address the issue of cancer as a whole and to save Iowans' lives. We need to expand cancer prevention, screening, and early treatment efforts. And as you saw in the presentation, with the exception of lung cancer, Iowa has a higher overall rate of early stage cancers, which can be most effectively treated or even cured. And that's why, as you all know, early detection is so important. And I think it further underscores the life-changing potential of Iowa's Healthy Hometown Project. As I mentioned in my Condition of the State address, this innovative plan to strengthen rural health care was recently awarded $209 million for year one of the Federal Rural Health Transformation Program. And of that $200 million, more than $50 million will be invested this year in our fight against cancer. And we expect that number to grow to $183 million in total over the full 5 years of that grant program. So this means more availability and accessibility for cancer screening, radon testing and mitigation, and specialty care cancer in communities statewide. To share more about what we're building and next steps, I'd like to recognize Dr. Cruz, the State Medical Director and Division Director of Public Health. Dr. Cruz?
Well, good morning, everyone. I'm Dr. Robert Cruz, State Medical Director for Iowa Department of Health and Human Services. And first, Governor Reynolds, thank you for your leadership and for bringing us together today. And also thank you to Dean Parker and the University of Iowa team for the work you just walked us through here today. As a physician, I'll underline one kind of point that I really want to reinforce here. Cancer is complex. Cancer risk and outcomes are influenced by multiple factors, individual behaviors, environmental exposures, genetics, and importantly, access to prevention, screening, and timely high-quality care. That complexity is not a reason to pause. It's a reason to be precise and intentional. Through the Cancer Drivers work, the University of Iowa has provided Iowa with a clearer data-informed understanding of where cancer burden is most significant, and which cancers contribute most to that burden, and how those risk factors and geography may be influencing patterns across the state. I also want to be clear that what you saw today represents preliminary findings. This is not the end of the work. This is really just an important milestone for us, and the analysis will continue over the upcoming year with additional refinement, validation, deeper exploration of partners, and so that Iowa can be confident in how this information is used to guide action going forward. That matters because when we understand what's driving the challenge, we can make better decisions about where to invest and how to target those interventions, and how to measure progress as well. Here's that connection I want to make this morning. The key drivers of cancer work by the university strengthens Iowa's ability to find that problem, certainly with greater precision. And Healthy Hometowns, our rural health transformation plan, strengthens Iowa's ability to act on that information at scale, especially in rural communities. Healthy Hometowns is built on a hub and spoke model, and what we call health hubs and centers of excellence, so Iowans can receive as much care as possible close to home and only travel when higher level specialty services are necessary. And specific to cancer, Healthy Hometowns involves a major initiative called Combat Cancer, Prevent and Treat. The objective is straightforward: reduce preventable cancer risk, increase early detection, and strengthen access to high-quality treatment and follow-up care, particularly for rural Iowans. Here is what that looks like in more practical terms. First, prevention and early detection under Healthy Hometowns, Iowa will expand colorectal cancer screening using FIT testing and critically support access to follow-up diagnostic colonoscopies, and for rural adults with positive screening results first, so screening leads to more timely diagnosis to care. Address radon exposure, because radon is a preventable risk factor for lung cancer, by expanding testing, supporting mitigation in rural homes where it's needed, as well as strengthening the workforce required to complete mitigation. Improving early detection of skin cancer by distributing dermatoscopes for rural providers paired with training, and to support early identification and appropriate referral. And expand access points for prevention and screening through trusted community settings such as pharmacies and telehealth-enabled tools to connect Iowans to better care in places that they already use and trust. Second, improving rural access to cancer treatment closer to home. Healthy Hometowns supports hub and spoke cancer care relationships in which regional hubs provide advanced specialty services such as surgical oncology and radiation therapy, while also rural spoke sites provide diagnostics, chemotherapy, and infusion services, follow-up care, as well as tele-oncology consultations through shared clinical protocols and coordinated care pathways. This is important because cancer is not just a single appointment. It's a continuum. It's consultations, imaging, lab work, treatment, follow-up, and survivorship care. Reducing that unnecessary travel and improving coordination, which reduces burden for patients and families while maintaining their quality and safety. Third, using data to guide our action. The cancer driver's work helps us to distinguish what aligns with those known risk factors and what may require deeper investigation. That allows Iowa to focus attention where additional analysis is needed and to target those interventions where they're most likely to improve those outcomes. And I want to be clear, this work builds a strong foundation. Iowa has had a long-standing cancer prevention and control efforts across public health, healthcare systems, and community partners nationwide, statewide as well, ranging from tobacco prevention and cessation to screening, promotion, to strengthening the systems, the support, timely follow-up of those abnormal results. This work is guided by the Iowa Cancer Control Plan and our statewide roadmap developed with our partners across public health, health systems, community organizations, and survivors to reduce cancer risk, to improve that early detection, to advance treatment and survivorship, and also to close those gaps in access. Healthy Hometowns does not replace that plan. It strengthens it and accelerates it. And it provides rural Iowa with additional infrastructure and support to implement proven strategies in a much more coordinated way. So I'll close with this. Cancer outcomes are not predetermined. Iowa can reduce preventable risk, detect our cancer earlier, and strengthen access to high-quality care statewide and across those rural communities, not only in our largest metro areas. And for Iowans watching today, there are steps that matter right now. Test your home for radon at least every 2 years and retest after major renovations. Avoid tobacco, and if you currently use it, make a plan to quit and connect with support that works for you. Limit alcohol. Even small amounts of alcohol increase cancer risk. There's really no controversy here among cancer researchers, even though you might hear conflicting messages about heart health. Maintain a healthy weight and stay physically active. Small, consistent changes can really make a meaningful difference over time. And protect your skin. This recommendation is really straightforward. Wear sunscreen, reapply every 2 hours, cover up with long sleeves and hats as possible, and stay out of those tanning beds entirely. And talk with your healthcare provider about which cancer prevention steps and screening tests are recommended for you, based on your age, your history, and individual risk factors. Governor, thank you again. And to the University of Iowa team, thank you for grounding this work in rigorous analysis and for helping Iowa focus our efforts where they can continue to have the greatest impact. Thank you.
Thank you so much, Dr. Cruz, for your leadership and your commitment to improving the health and well-being of Iowans. I have no doubt that the steps you've outlined will make an incredible difference as we take cancer head-on in our state, and our fight is already underway. You know, as soon as we submitted our Healthy Hometowns plan to receive federal funding, the agency took action. opening applications, engaging the medical community, and prompting over 250 proposals from across the state. And last week, Iowa was the first state in the nation to begin awarding those contracts. This morning, I'm pleased to announce additional contracts that will specifically support our fight against cancer. And I'd like to have Health and Human Services Director Johnson do the honors of making that announcement.
Thank you, Governor Reynolds, and thank you to my team who's been working tirelessly on this effort. I am proud to announce our intent to award the first phase of cancer-specific contracts, a significant step in turning $50 million investment into life-saving treatment and screening. Marion County Board of Health has been awarded the cancer screening and prevention contract and will help generate awareness about the importance of screening and prevention, purchase and distribute cancer screening tests and equipment, facilitate a radon mitigation initiative, and more. I'm excited that we're able to leverage our existing public health resources to support this critical project. This type of work is exactly what public health is intended to do, and we look forward to this partnership. University of Iowa Healthcare has been awarded the Cancer Health Hub Technical Assistance Provider contract to help lead the development of cancer hub and spoke models that Dr. Cruz described. They will make everything from advanced specialty care to diagnostics, chemotherapy, and follow-up care accessible across rural regions. As Iowa's only comprehensive academic health system, UI Healthcare will be a strong partner to help us transform cancer care across the state. Thank you.
So thank you, Larry. Thank you for your leadership and to you and your team's proactive approach, really, to moving these contracts forward. I want to thank you. I want to thank Dr. Cruz and, again, your entire team at HHS who have been working on both Healthy Hometowns and the Cancer Research Project alongside the University of Iowa. This work will have a lasting impact on our state, and I appreciate the commitment of everyone involved. And as I said in the condition of the state, this is how transformation begins. Not just with talk, but with action. And when it comes to fighting cancer, Iowans deserve nothing less. And that's why I'm confident that we're not only on the right track, we're taking real strides towards a healthier future for our state. So in addition to the cancer research study and our Healthy Hometowns project, we've also refocused food assistance programs on nutrition to encourage, again, those healthy behaviors. Today, I'm introducing a bill that requires that approach to continue. It also proposes to eliminate certain dyes and additives from school lunch programs, requires physicians to complete a nutrition course as part of their continuing medical education, and raises existing taxes on cigarettes and tobacco products, and institutes a new tax on consumable hemp and vape products. Today's research findings make it very clear how important healthy behaviors are for the overall health and well-being, and my bill aims to really amplify that message. So in closing, again, I think we've all kind of said it, but I want to reiterate our commitment to sharing information about the cancer research study when updates are available. We have shared a lot of information today about the key drivers of cancer, and Iowans will be able to read the initial report on my website at governor.iowa.gov. And with that, we'll open it up for questions.
Governor, pardon me, acknowledging that this is preliminary results, but given everything that you heard specifically about lung cancer incidents, are you planning on advocating for repealing casinos' exemption from the state's public smoking ban?
Well, I've included what I have in my bill, and that's a separate bill, so we'll let it work through the legislative process, but I'm going to be doing everything I can to drive the components of my bill that I just laid out. We know that that's a major cause to lung cancer, and I think it's something that we need to take very seriously.
We looked today at a lot of demographic, behavioral risk factors, things like that. As you're moving forward with this and looking potentially county by county, how do you plan to address and look at different environmental factors? What people live near, what they're eating, drinking, other pesticide access, things like that?
Does somebody on the team want to address that? Because there's not a lot of state or national data out there for us to
Right.
compare to, which makes this just a little bit challenging.
Right.
The areas that they started with, there's a lot of data out there that we can compare and start to drill in and look at the drivers, and that's what they'll continue to do with the counties. But I'm going to let the experts talk a little bit more about what that means.
Yeah, thank you, Governor. I think Governor Reynolds identified what one of the challenges will be. So as I mentioned, we're trying to compile what data is available there, working with partners across the state, water quality data, the challenges that, for example, well water, some are tested, some aren't, so there's going to be some gaps in that, but there are pretty good data on water systems throughout, so we'll be looking at that also. Radon, we're trying to, because there is testing on that, so we'll take a look at that also. Some of the pesticide data, we can get some data on who applied to be an applicator. The data is more challenging on where that applicator applied the data. So this is really, we spend a lot of time with some of our colleagues trying to find out what is out there, and we'll continue to do that, working with experts across the country. We've been in contact with folks with the geological, USGS, as well as folks at NCI who's sort of taking a look at some of that also. So I think trying to do all we can to take a look at that. But as my colleagues here pointed out, I think our strategy will be particularly those where we have that unexplained percent. Dr. Olson showed that. So those are probably first priority to look at why they're unexplained, reasons for why we're in excess, and kind of drill down on that as much as we can with what the data we have. So, thank you.
The research several times pointed to a potential change or potential increase, right, exponential increase starting around 2013, 2014 in this trend data. I wonder if you could speak to what we might know or not know about what drove that increase, what happened around that time to lead to such an increase in the cancer rates.
Yeah, and it's really tempting to think it is something around that time that changed, and we've certainly looked at our data collection procedures and anything that might explain such a sharp turn. But the reality of cancer is, in terms of exposures and risk factors, the risk factors now don't cause cancer now. It might have been risk factors from decades ago that are causing the cancer now. With prostate cancer, the more you look for it, the more you find it. So it can be sensitive to changes in guidelines for screening or just provider practices. That's when it's a unique screening test in that you don't have to go make a separate appointment for a mammogram or a colonoscopy or something. It's just a blood test that can be added on during your provider visit. So that's why one phase of this project is really looking into provider patterns around diagnoses. Could they have started to look for it, in different ways and in different areas? But we have not been able to figure out anything that changed at that time period that would cause the data to change in the way that it did. So I think, again, it's some complications of risk factors from a while back and some added factors within our healthcare system that we'll keep digging into to try and explain that.
I know you said Iowa is on the higher side in terms of rate insured. Has that been true all along, or did that grow over the last decade in a way that led to more diagnostics?
Yeah, I think we tried to lag a lot of these exposures, so Dr. Olson might have to talk about the exact time period that we went back, but we didn't, these exposures and these behaviors that he included in the models weren't from right now in this time period. We tried to go back 5, 10, 15 years to see which time period would be the most predictive. So I can't speak to exactly the changes in health insurance rates now. But they certainly do play a role. You could see, if you compare Iowa's cluster to that southern cluster of states, who arguably have some worse behaviors or different behaviors than we do in Iowa, but also arguably have worse access to healthcare. So if you're looking for things like prostate cancer less people are going to the doctor, less people have insurance to pay for it, less people will be diagnosed with prostate cancer. The hard part about cancer is you don't know which prostate cancers might grow to cause problems and which ones won't. So there's a lot of complexity within that too. And I imagine most people who had their cancers found early are really grateful that they had them identified and removed. But there is also the possibility that some people could have had cancer and never known it for the rest of their lives. So that's kind of mixed in with all of this complexity of trying to model these rates.
I don't know if this is a fair question or not, but in light of the, when you're looking at the time period there, 2013, 14, maybe when we started going south, is it more likely that for whatever reason we were exposed to bad stuff, or are we listening to our doctors less and not doing the things that we can prevent on our own, eating, drinking, smoking, working out, all that kind of stuff?
Yeah, boy, that's a really tough question to answer, especially like I said, with most of these cancers take at least 10 years to develop. So to pinpoint something that would have happened right there is really difficult. If you look at the trends, and I don't have the slide up, but we did experience a decline in breast cancer just before that, where most other states experienced their declines a little longer ago. So then our decline right before 2013 makes our trend steeper as it goes back up. So that doesn't explain everything, but it might explain why our rate is different from everybody else's. And we tried to figure out at the cancer registry, did a hospital forget to report to it? Like, was there something going on that year? Were we missing cases and we couldn't? It was systematic across all of our hospitals and places that report to us this decline. So we don't know why that is. So we continue to dig, but again, if only, you know, the risk factor preceded the cancer by just a year or so, we could really hone in on that time period. But the reality is it goes much further back. So it could be that Iowa providers, even after the guidelines changed with prostate cancer screening, if you remember, I think around 2012, where they said, talk to your doctor. Instead of doing it every time, every 50-year-old plus male should be getting it every year. It became talk to your doctor, and it was downgraded by the USPSTF in their guidelines. And it could be that other states, other providers in other states took that to heart more than providers. It's still really good information, and I think you'll hear the urologists and other doctors argue that's a really important data point, and people want to know if they have cancer, so we want to be encouraging that. But again, some of this can be just caused by variation in diagnostic practices of our physicians. I don't think that's what's causing all of it. I do think it's a contributor, and your question is just a really hard one to answer from the risk factor standpoint as to what could have happened. But breast and prostate don't share a lot of risk factors other than hormonal types of factors is really the only thing I see across the two of them from a pure risk factor standpoint, which is why it's just so important to keep layering on data as we get it about other types of risk factors. That's not a very satisfying answer to your question, I'm sorry.
Will the Healthy Hometowns project look more at lung screening, because a lot of insurers will only do lung screening if you've been a smoker for a certain amount of years? Is that, so with Iowa's high levels of radon, is that something that could be opened up with that funding?
Yeah, good question. You know, it's our focus is on all sorts of screenings. You know, I think that we are looking at the continuum from prevention to early detection and screening to treatment to survivorship, and all those components that are building off of our current cancer control plan. So I think, you know, as part of that strategy is also going to be around lung screening. It's going to be around fit testing. It's going to be around you know, really all those individual tests for those screenings for different types of cancer. So we really look at that as really an opportunity for us to use this as an investment for us to really help to understand really more of those cases that we may be missing in rural communities, and to get early detection and get people back to treatment earlier. So, good question.
Kind of on that, as you looked at behavioral and demographic factors, was smoking considered in line with what we would expect for people who had reported smoking versus higher incident rates that were found throughout the state? Did that?
I'm not sure.
So other factors like obesity were considered when looking that might contribute to higher rates of cancer in Iowa. was smoking considered one of the factors when looking at Iowa's higher lung cancer rate, and where were instances that the rates were higher?
Sure, so we haven't done the modeling.
I know.
So as Dr. Olson mentioned, we've only done the modeling for prostate and breast cancer. It will absolutely be considered in the modeling for lung cancer. One variable that we really need to keep going with the modeling of lung cancer is a good radon variable, which takes a little bit of doing. So we are working on that. But certainly we considered smoking in some of the other cancers, given that it's such a risk factor. But sometimes we have to pick, like if we put too many variables in there, it makes it's called overfit, and it makes the model not quite work as well. And as you can imagine with any of these risk factors, these are county level or state level risk factors. We're not looking at individual data. But you can imagine that some of them overlap with others. People who have one behavior are more likely to have another behavior. So sometimes some of the usual suspects that you think would be in the model might get overshadowed by another variable, behavioral variable that sort of captures that also. So that's also kind of part of the complexity. And as Dr. Parker said, we wish we had individual level data on everybody, and we certainly appreciate like the people who don't smoke and don't drink and still got cancer are angry. They want to know why they got cancer, and we wish we could tell them, but on an individual level, it's just so difficult to be able to do that. We do know that on a population level, that these variables that we're looking at are highly associated with cancer rates. So
Is it about 70%?
that's
What statistic was that, I think, right? Or am I mixing apples and oranges?
I think in terms of like incidence, I think I see the CDC says things like at least 40% of cancers are based on modifiable risk factors. Now, but we've also introduced demographics and other things that are not modifiable, so that kind of gets us up more to the 70% that we're talking about.
When we look at both of them.
Healthy Hometowns initiative. Part of, I would imagine, that is not only just increasing access and having more programs and opportunities, but also building up your workforce. I know we've talked in the past about just shortage of doctors, epidemiologists, people that are able to do chemotherapy and programs like that. How do you not only make sure those resources are in place, but also you're recruiting and getting people to come and live here and carry out those programs?
Yeah, good question. I think, when we think about workforce shortages, it's certainly a real challenge, certainly in rural areas. Healthy Hometowns, certainly addresses this by supporting some of those hub and spoke models and telehealth, also some of those shared clinical protocols, and also training around that. I think it's allowing those rural practices to really, providers to practice up to their level of their licensure. So with still remaining kind of connected to our specialty care as well. So I think we are thinking about using our Iowa Hometowns to help to support those providers in those different settings, to help equip them with the capacity to help those demand for those specialty care. I think this builds off of kind of our programs that we have within Iowa HHS around how we kind of attract people to the state of Iowa regarding kind of our providers. And it's not just physicians, it's all sorts of healthcare individuals as well. So, but Healthy Hometowns just helps to augment a lot of that and bring that even closer. So I think we're building capacity through several of our programs, and certainly with Iowa Healthy Hometowns, we're focused on that efforts as well.
It's one of it definitely builds on what we did. It's why last year we increased the amount that we're putting into loan forgiveness so we can get them there. It's why we're looking at the residency programs. It's why we're creating an environment in our state that's attractive to keep those professionals in and build out that workforce. So this will just allow us to kind of stack on top of that and provide additional resources and be a partner in helping build out that workforce, which again, every single state is dealing with. COVID just diminished our healthcare. It was so hard, and so every single state is still in the process of building back for that as we try to, and especially as we're trying to stand up rural Iowa with these services. So, getting them to locate there. We get them there and have them practice for 5 to 7 years, we keep them. It's just getting them there, and then we've got them. So we'll do an all full-out marketing campaign, and again, look at different incentives that will help them really think about Iowa, staying in Iowa, and helping address some of the shortfall.
I know you mentioned it could be up to $180 million. specifically dedicated to cancer over the next 4 years. Can you talk about how this is sustained though, beyond that?
Well, a lot of it's infrastructure, and a lot of it's equipment, and a lot of it's training. So it is one-time money, and anything that I take on that's one-time money, I make sure that it meets the test of not being an ongoing expense. So we have to be strategic and we have to be thoughtful about how we build out that hub and spoke, that specialty care, how we bring those professionals into the state. So, and as Dr. Cruz and Dr. Johnson, or Director Johnson pointed out, I mean, they've been doing a lot of great things at the Department Health and Human Services, and so we have a really good foundation to build on. Our centers of excellence. We went to the legislature and we asked for some grant program dollars. Each one of the hospitals that utilized that, again, knew that it was 3-year funding. That was it. Then they had to put in their application how they were going to sustain it moving forward, and most of them have been able to do that. So we have a really good proof of concept on how we can now do that in other areas of the state, really specifically working on different specialty care. So, you know, we're talking cancer today, but there's a lot of other areas that we intend to build out as well.
Governor, there haven't been many times when we've heard you step before a microphone and talk about raising taxes.
I know.
Um,
Thank you for starting your question with that.
Reality.
Yeah.
Can you explain kind of your thought process when you're talking about increasing tobacco tax, vape, all that kind of stuff? Like what goes into that? Why do you think that's the right approach?
Well, national statistics say that, you know, 80% of lung cancer is caused from tobacco. And so as we're looking at all of the other levers, I don't think that we can set one component out of it when it's 80% of the narrative aside and say we're not going to talk about that. So, you know, I felt that that was appropriate for us to do that, as we really, our numbers are not, you know, they're not acceptable. We have to be better. We got to understand it. That's why I'm so grateful to the University of Iowa and this team that's had the opportunity to present. So, because to give us data and to have them be able to drill down and be really strategic on how we go at the cancers and prevent and screen and, you know, and early detection. I mean, that will help us really allocate these dollars in a more responsible manner. But it's just part of the equation, and well, it's the right thing to do. We're looking at nutrition. You know, people didn't like some of the things we did there with Healthy SNAP and some of the waivers and the summer EBT, but it's the right thing to do. Just look at the data. So when you look at the data, this is probably the right thing to do.
Governor, you're tackling this as the state's chief executive, but obviously this is also very personal for you. Do you ever find, I'm curious if you ever find yourself in moments as you're working on this and you're being briefed by UI folks, do you have moments where you find yourself looking through it and thinking to yourself, for lack of a better way, why Kevin?
Well, yeah, no, I did, even when they were presenting the statistics, both earlier and here again, the numbers aren't good for lung cancer. They're just not, and it's really hard to detect. And Kevin's, it's a fast-growing lung cancer, and I don't think probably if it hadn't metastasized to the spine and he was in so much pain, I'm not sure we would have found it soon enough. And Kevin doesn't smoke, has never smoked. He's, you know, pretty trim and fit. I think he's getting a little bit of a pot belly here. You know, as we get a little older, that's kind of what happens. I'm on him all the time about, hey, get back on that, get off that sugar. You know, but really and he's very active. We all keep him very active at home. So he is not somebody that you think would even experience that. But it is in his family history. And so, you know, but we were, you know, I know that sounds odd, but we were blessed almost for him to have that metastasized, and he was just in so much pain that he put up with even longer than he should have. But we got him there and found it and got right on it and did all the other scans, and it wasn't in the brain and it wasn't in the other major organs, and we were able to take advantage of the immunotherapy that shrank the tumor in 6 weeks. And so, you know, as technology and innovation continues to, I think there's so much hope and opportunity out there, as Dr. Broker told us. You know, this is fighting the cancer, and you're in remission, and it's going well. At some point, your body will figure out probably how to get around that, but at that point, there'll be a new immunotherapy that we'll be able to identify for his type of cancer that we'll hopefully shift to and take it head on. But it's hard to hear the statistics, I won't lie. It's a gut punch when you get that call.